All right, so we've covered kidney basics, chronic kidney disease, acute kidney injuries, and now all of that's gone poorly, and we need to go talk about dialysis. So we talk about this as renal replacement therapy, which is really what it is. It doesn't help the kidneys in any way, it just replaces what they do. So get ready to talk about dialysis. So by the end of this here, you'll be able to list the indications and the risk benefit of starting renal replacement therapy and describe the factors allowing transition between the modalities and maybe even stopping renal replacement therapy. And then identifying long and short-term complications of dialysis. So renal replacement therapy in broad terms provides clearance, which is removal of toxins and correction of electrolytes, and then we can remove volume. So those are the two main things that we start renal replacement therapy for. So there's four major indications for starting renal replacement therapy: hyperkalemia, hypervolemia, metabolic acidosis, and uremia. So basically with all of these, there's going to be things to try first before we start dialysis because there's always risk associated with starting dialysis. So fix hyperglycemia and acidosis. If your pH is under 7.2, you can try and fix it, hopefully with some bicarb if it's not a respiratory acidosis, if it's a metabolic acidosis. Certainly if they're hyperglycemic, fix that and see what the potassium ends up being and see if you can manage it medically. If they're still making urine output, you can give a loop diuretic and fluids depending on their volume status. So if they're dry, you can just give them fluid and see what happens. If they're euvolemic, you can give them fluid and Lasix. I usually think about 40 of Lasix and half a liter of some sort of isotonic fluid, so that's LR or normal saline. And if they're hypervolemic, you can skip the fluid and just give them a loop diuretic and see if you can get some potassium essentially out into the universe. In the ICU, I'm not a big fan of KX-Late because these patients tend to have low blood pressures. Their gut is one of the first things that gets reduced blood flow. And KX-Late, if it just sits in the gut and doesn't move, it becomes kind of a rock, and it's been associated with bowel perforation. So it's something I try and avoid in the ICU. Shifting with insulin and D50 will buy you some time, but it's going to come back. So it works quickly, 10 to 20 minutes, but it only lasts about 4 to 6 hours, at which point it's going to start seeping back into the bloodstream. So unless you have some plan that they're going to be more stable or they're going to be able to get rid of some potassium before then, shifting is just buying you some time, hopefully to get a catheter in or something like that in order to really fix their potassium. And certainly the intake part is something we always focus on. If they're starting to have a kidney injury, look at your tube feeding diet, and if we're trying to avoid dialysis, use the lowest possible potassium in all those things. Once they're on dialysis, we can actually manage this pretty easily. So I tell dietitians once we start CRRT or intermittent HD that go ahead and give them whatever the best nutrition is for them, and we'll deal with the potassium. But in that time where we're trying to avoid dialysis, that's when you really want to use a low potassium tube feeder diet. The second indication for starting dialysis is metabolic acidosis. So again, this is not just a low bicarb on the BMP, because patients can definitely compensate with their respiratory drive. But if the pH is generally under 7.2, that's when I start trying to give bicarb, either isotonic or concentrated, and considering dialysis if it really looks like that's not going to work. So IV bicarb, as I mentioned, comes in two basic forms usually. So isotonic bicarb is 150 milliequivalents, so 3 amps of bicarb in a liter of D5, and that essentially is isotonic. And the ampules, the 50 milligrams that you get in crash carts, are really hypertonic, so 8.4%. There are times I come look at a chart for the first time and they've gotten 10 amps of bicarb and their sodium will be 160. So watch out for that. If they need fluid, isotonic bicarb is a really great choice because certainly if they have an acidosis, because you can kill two birds with one stone in that you're giving them volume and you're giving them bicarb without a chloride load. So dialysis provides the bicarb without these issues, so that's sometimes what we're forced to end up doing. As we talked about in the AKI section, patients are usually in one of three phases when it comes to volume. You're volume expanding them because they're septic or have low blood pressure. You're maintaining them and you're just trying to keep them even. Or a lot of times we over volume expand people and you're in the diuresis or volume removal. Low albumin with sepsis and other ICU issues, also causes third spacing of fluid that we can't diurese off until patients just plain get better. So albumin always drops in acute illness, and then it gets better as patients get better. So once that starts happening, you're more easily able to remove volume. So just always think about and even document in your note where you think your patient is in these phases. And in that spirit, low urine output in and of itself is not an indication to start dialysis. So if you're still in that volume expanding phase and the urine output is 0, you're still not going to think about starting dialysis to remove volume because you're going to cause worsening hypotension and all sorts of other problems, and even a worsening AKI. So loop diuretics are always okay, especially in that maintaining or volume removal phase. Sometimes you're giving loop diuretics knowing you're not going to be net negative. If you're going to give somebody 4 liters of fluid today because they're on multiple antibiotics, multiple vasopressive drips, an anticoagulant drip, these things just tend to add up, and I see patients often get 4, sometimes if they're on ECMO or things like this, 5 liters of fluid in a day. You may give them a loop diuretic knowing you're not going to make them net negative, but you're just preventing worsening volume overload that you have to deal with down the road. Ultimately, if you need to remove volume and urine output has just dwindled to 0 and you're past the volume expanding phase, dialysis is definitely something that we start for volume. The fourth reason we start dialysis is uremia, which is a buildup of unmeasurable metabolites that start to impact patients' mental status and sometimes their neurological function. So one of the tests we do is have patients hold up their hands, and if they're uremic, you often will see what's called asterixis. And I put a video up there with a link, and it looks like patients are kind of flapping their hands uncontrollably. You can see this. It's also noticeable in liver disease, so it's definitely not specific just to kidney disease. So a lot of times we're ending up starting dialysis just because it's something that we can fix and see how the patient does. One thing I want to stress is uremia is not a BUN of over 100. BUN is a very poor marker in ICU patients who are getting tube feed with high protein loads. They have a lot of GI bleeds, and GI bleeding is a sure way to get your BUN up very drastically. The blood goes in your gut, gets broken down by the acid, and the BUN gets reabsorbed, so your BUN goes up without a filtration problem necessarily. So certainly when the creatinine is going down sometimes after kidney injuries and the BUN continues to go up, one of the first things I think about is a GI bleed. The uremia is not a common phenomenon in inpatients. This is something we watch in the outpatient population for months to years sometimes. If a patient has a GFR in the low teens, we will see them every week or two, have them do these tests for asterixis. We'll ask them about their appetite, any unplanned weight loss. These are things that suggest patients are uremic. It definitely takes more than a few days to be a factor. So if a patient's creatinine was normal 2 days ago and they have, let's say, a cardiac arrest, and all of a sudden the creatinine and the BUN are way up, certainly they're not going to be uremic after 2 days. If we're a week in and they're not waking up and their CT scan looks fine, then we start thinking about should we start dialysis and see if this patient clears. I will say this is poorly studied, but we do remove a lot of medications. We remove ammonia with dialysis. So sometimes we start dialysis, patients wake up, but it may not have been their kidney disease that was really making them so altered. We may have cleared a lot of their sedation. So we determine our patient needs dialysis for one of these 4 indications. So now what do we need to do? First, we need to think about their prognosis, as this is always a question that comes up with family. Starting dialysis does multiply their mortality several-fold. Even just having an AKI does that as well. So timing of it, starting early has never been proven to benefit patients. And there's multiple studies of this. The most recent just came out early last year. 12,000 patients. They basically sorted them into likely to need dialysis patients, put into two groups, one to start immediately and one to wait for one of these four indications. There was no survival benefit in starting early, and actually 50% of the people that waited for a solid indication ended up recovering before they ever needed renal replacement therapy. So this is something I quote often to residents or people that are really thinking that dialysis will help, that unless you can really point to one of these four reasons to start dialysis, we should really wait. Access is probably the first hurdle, and temporary IJs are usually the first option in the ICU at least. Sometimes femoral, depending on what their vasculature or other access issues are. If they have advanced CKD, let's say we have somebody with a creatinine of 3 and they've been followed in kidney clinic for quite a while, nearing dialysis but haven't started, and they end up in the ICU with sepsis, there are times I will jump right to a tunneled line because the chances of recovery in the short term are pretty low. So certainly we'll be thinking about this as a kidney team. After 2 weeks of renal replacement therapy, if there's no signs of recovery, I'm starting to think about a tunneled line. They're better for infection reasons. They tend to be a little more durable and they give better flow rates with dialysis. So if your patient is really not showing you much after 2 weeks, that's when I start to think about it. End-stage renal patients will often have their own access, and it should be a fistula if they've been on dialysis a long time. This is not usable for CRRT, so if a patient is unstable to begin with and really needs CRRT, we will have to put a catheter in, or often these patients can go a day or two without a run of dialysis, see how they respond to treatment for their underlying issue, and then run them when they're more stable using their fistula. So it all depends on what their indication for dialysis is. And we'll talk about the decision on modality. So CRRT is continuous renal replacement therapy, and intermittent hemodialysis is the type done in DaVita's and Fresenius strip mall DaVita, I often call it, across the nation. This is really meant for fairly stable patients and done 3 to 4 times a week. But sometimes in the ICU, we can get by with staying off of CRRT and running them every day is another option. Either way, we try and start slow, as removal of a large amount of toxins right away can be harmful to patients. So if you think about the osmolarity of blood when toxins build up and in the brain are both very high, and then you do an immediate run of dialysis and clear lots of toxins and lots of osms, you leave the osm in the blood low, and the osm in the brain doesn't change as fast because the blood-brain barrier is semi-permeable. So you leave a high osmolarity in the brain, and water crosses easily and can go into the brain and cause brain swelling. So you'll often see the first dialysis runs we do are 2 hours with half blood flow, and that's really what we're thinking, is to just start slowly. There's usually no rush in getting them cleared, and we'll do it several days in a row with that approach. So intermittent hemodialysis, this is what I always call strip mall dialysis, and it's meant for fairly stable patients. Blood flows through the machine are typically 200 to 400 mils per minute. 200 would be what I would start with on someone who's never had dialysis before. And patients that are well established can get 400 or sometimes even 450 milliliters per minute through their fistula through the machine. Runs are 3 to 4 hours. You can run longer, which is called scuff. These are usually in institutions that don't have continuous therapies. A lot of their prescription is based on their weight and how their chemistries have trended over long periods of time in their outpatient dialysis. So I always call their dialysis unit and find their rounding report and see how long they run and how many times a week. And often they'll put if they stop earlier or have missed runs and things like that. It's meant for 3 to 4 weeks for stable patients, like I keep saying, although we can do it daily for shorter amounts of time to stay off of CRT, particularly if patients are working with therapy or have other things in their day that they don't need to be tied to a machine for. I will say it's difficult to be net negative long term with intermittent dialysis because you try and get maybe 2 to 3 liters in an intermittent dialysis run over 3 to 4 hours. But if your patient is getting 4 to 5 liters in a day, these are typically our ICU or ECMO patients, it can be really hard to keep up with intermittent hemodialysis, even running on a daily basis. So before I consider this modality, how much patients get in is a big factor, and where we are fluid balance wise. So if they're starting 20 kilograms up and it's all fluid, you may want to think about CRT just to get consistent fluid removal for at least a few days before you think about intermittent dialysis. Continuous renal replacement therapy runs all day minus downtime for road trips to IR or OR and when the machine clots, which typically is a little more than a day, although sometimes they can go up to 72 hours if a patient's heparinized and things like that. It's more physiologic than intermittent HD because it's more like a regular kidney that's working all the time. The blood flow is 1/8 of what you get with intermittent HD. So the hemodynamic effect is much less. The rapid clearance issues that you can have with intermittent HD and water shifting in the brain is not there. And you can pull fluid every hour, so you get more consistent fluid removal. It does not correct chemistries very quickly, and that's just because of what we just talked about. The blood flow is about 1/8 of what an intermittent run is. So if a patient's potassium is 7.5, even if they're hemodynamically fairly unstable, we will try and run them for even an hour of intermittent HD because it's worth about, as you can see, 8 hours of CRRT. So a common thing we'll do is run them for an hour or two of intermittent and do whatever we need to do to get them through that. If they need blood, this is a good time to give it to them. And then once they're done with intermittent HD, we will put them on CRRT. They can have more clotting issues than intermittent HD just because they're on all the time. If the circuits are lasting less than a day, I usually see if I can put heparin through the filter. So I'll check with the team and make sure there's no contraindication to that. So this is a schematic showing the differences between intermittent HD and CRRT. So on the left is intermittent HD, which has been used for many decades. Blood comes from the patient, runs through the filter, and returns to the patient. On the other side of the membrane in the filter, it's bathed in a dialysate, which is running the opposite direction to maximize the amount of metabolites that are removed. And that ends up being what we call the ultrafiltration, or our fake urine. So while the blood is in the chamber, pressure can be applied to it and fluid removed, which causes the patient to lose fluid, essentially. On the right is CRRT, which of course blood comes from the patient, and before it gets to the filter, we mix it with a pre-filter. So this basically looks like what you want the plasma to look like. So the potassium can either be 2 or 4, depending on what you want the patient's potassium to be. And then it's got bicarb and calcium and all these things in it. So we mix the blood before it even goes into the filter. And then the filter also has dialysate, which serves the same purpose as the intermittent hemodialysis. While the blood is in the filter, we apply pressure and remove fluid with UF. In post-filter, we run a small amount of fluid, which again just looks like what we want the blood to look like. So CRT at our institution actually has 2 different kinds of clearance. So it's a bit more complex, but it runs so much slower that patients tend to tolerate it a little better. So the bottom line is both modalities accomplish the same goals. It's patients' hemodynamics and volume status that determine which modality we use. CRT has never been shown to have a survival benefit in any trial versus intermittent with just using more vasopressors to keep your patient's blood pressure stable. The thing that really pushes us is just how patients are responding. If their blood pressure is low, if they have very high BUN, or if they have liver failure with suspected high levels of metabolites from that, we start with CRT because it tends to be more gentle. So hopefully your patient will eventually stop needing dialysis. When do we start hoping for that, and when do we stop dialysis? So once they're on intermittent HD, and off of CRT, we can watch the creatinine when we're able to give them a day off of dialysis. So creatinine on the day after dialysis gives you virtually no information besides planting a fence post for tomorrow's creatinine. So if a patient has a creatinine of 4.5 and you dialyze him today and his creatinine is 3 tomorrow, you really won't know what his kidneys are doing until the following morning when you see where his creatinine goes from that creatinine of 3. You can use diuretics to augment his urine output, his or her urine output, once it's about half a liter in a day. You can combine this with thinking about the clearance based on what the creatinine does to see whether we can give a break from renal replacement therapy. Often what we'll do is stop CRT with the goal of getting a patient to every other day dialysis. And then once we're able to skip 2 days and then 3 days, and then sometimes by that point they're recovering. So you really don't know once they start dialysis until you're able to give them a bit of a break. End-stage renal disease is something we typically diagnose 3 months after renal replacement therapy starts. So in my note, I always put the date of starting renal replacement therapy, whatever the modality. And there are certainly exceptions to this. I've had a lady that recovered 4.5 months after starting dialysis. But typically, if somebody's needing dialysis 3 months after their initial injury, it is very likely they're going to need it going forward. So these are things I just wanted to put as a side note of what to put in your progress note in the renal/electrolyte section of your note. These are things I'll try and always have in my note. Their baseline creatinine, if they have CKD, what their stage is, if they do or don't have proteinuria, what it's from. Their fluid status, are we volume expanding them? Are we trying to maintain? Or do we think they're overloaded and we need to eventually get fluid off? If they're on renal replacement therapy, certainly the date of the start of their renal replacement therapy is always important to have. Their current renal replacement therapy access, do they have a temporary line? Do they have a tunneled line? When was that put in? Do they have a fistula or graft? And these are things that help us keep track of where we're at if we need to get radiology involved to get permanent access. So here's some further reading on dialysis. I'd highlight that the history of dialysis is very interesting, especially the ethical considerations when it was such a limited resource back in the 60s and 70s. And Richard Nixon actually made end-stage renal patients automatic Medicare patients. So he was the one that really paved the way to starting dialysis as a main therapy. Timing of initiating renal replacement therapy is a great study, and it's something I use almost every day in my notes.